So we're fortunate in CLL now to have many different good therapies, and one of the goals in the frontline setting for younger fit patients is to develop time-limited regimens, and potentially even ones that have curative potential. And we know now from long-term data on FCR patients that some of these patients can be cured from FCR alone. These tend to be mutated IGHV or lower risk patients, and so the aim of our study was introducing Ibrutinib in combination with FCR to try to improve the rates of cure for both the mutated patients and unmutated or higher risk patients' IGHV status. So in our study, we combine Ibrutinib with FCR for up to 6 cycles of treatment, and then all patients get 2 years of Ibrutinib maintenance therapy after that. And patients have to be previously untreated and age 65 or younger, because we're targeting this to a young, fit population. And at this ASH meeting, I'm going to be presenting the results of the first 35 patients that we've treated in an oral presentation. And what we've found actually is that we're seeing very high rates of response. 100% of patients have responded. But even more importantly, we're seeing very deep responses. In particular, we're looking at the rates of minimal residual disease, or MRD negativity. And what we found over the course of the study is that 83% of patients have received therapy and gone into MRD negativity in the bone marrow. As far as we know, this is the highest rate of bone marrow MRD negativity ever described for a regimen in CLL. And so we're optimistic that many of these patients will have long-term disease-free survival. And importantly, this regimen has been well tolerated. We've seen the usual expected toxicities of Ibrutinib and FCR, but no additive or synergistic toxicities. So what we're exploring now in a larger 50-patient expansion cohort is whether we can actually discontinue Ibrutinib in patients who are MRD negative at the 2-year mark. And potentially this will allow us to have a time-limited therapy for CLL patients, because some of these patients may be cured with our therapy, and if they're not and they recur, then those patients can go back on Ibrutinib at that point. So stay tuned for future developments with this study, but we're certainly excited about the initial results we're presenting at this meeting.